Good morning. Welcome to the Doctors In Ask Dr. Arwady. I'm Sybil Madison, your Deputy Mayor for Education and Human Services, and I'm here with Dr. Allison Arwady, your Commissioner for the Chicago Department of Public Health. This is where you can get the latest on COVID-19 in Chicago, and you can get your questions answered. You can put those questions in the chat box below, or you can send them to us through Facebook or Twitter using the hashtag AskDrArwady. If you've been with us before, you know we always check our social distance as we talk about coming out of sheltering in place. We hope that this is something that people do when they are in their workplaces, if they are returning to work. And it's also just important when you're out and about taking care of essential tasks that you are keeping that distance away from others, whether you have a mask on or not. And you should be wearing a face covering if you're in a place where it is hard to keep that 6 feet distance. So, Dr. Arwady, I'm going to turn it over to you to give us the latest.
All right. Sounds good. So today is Monday, May 11, and if you take a look, as always, at chicago.gov/coronavirus, you can go and get the latest information. We actually did a big refresh of the website over the weekend, and so a lot of things are laid out a little bit differently. We're still working on moving some pieces around to make sure things are easier to find.
There's so much on there, so we have to keep making it easy.
Exactly. But right up at the top, there's the tab that says Latest Data. And that's where you can pull it up. And I'm actually literally on the website here as I'm talking to you. So we are at 30,921 cases of COVID-19 in Chicago residents and 1,356 deaths, again in Chicago residents. That is among 77,741 in Illinois and cases and among 3,406 deaths in Illinois. The US, over 1.3 million, the world, over 4 million cases. In terms of our testing, we continue to make some progress there. We've now tested 108,757 individuals. And we had a question the other day, actually, about sort of individuals versus number of tests. And we actually we count individuals who are tested. So sometimes people may have to get a couple of tests, but not usually. And so we actually just count individuals because it's the best way to know that you're having testing widespread. You might be in a healthcare setting, for example, where people may be getting more frequent testing. But for this overall number, we actually talk about individuals. So we are testing on average 3,056 individuals per day. That's our 7-day average. And our percent positivity is 24.6%. You'll remember
it's going down.
It's going down. You'll remember that's the how many are positive divided by how many are done in total. And so we want that number to go down. In some of the state opening guidance, they've set 20% as the line for that. And there's a little more detail in that. But we've also
we have a target of 15. Is that
we have
right?
the target of 20% is sort of 4 overall, but we've broken that down and divided it up into our congregate settings, meaning the long-term care facilities, the jail, the homeless shelters, places where CDPH is in, working with partners and others to make sure that we're doing more universal testing. We actually sort of expect to find some higher rates there. They're higher risk settings. And so we've set as a goal trying to get below 30% positivity in those congregate settings and then below 15% positivity in the community settings. And that's just our initial goal. We actually are hoping to, as sort of the months go on and we sort of move through phases, get probably even further down to, ideally we'd like to be at a point where we're maybe only seeing about a 5% or even lower positivity. But for, thinking really over these next few weeks through likely the end of May with the hope that we'll be able to lift the stay-at-home order and move into that next phase 3, cautiously reopen, at the end of May, beginning of June, that's what we're aiming for. So making some progress. I will not get, into any more details. I'll encourage you to go on the website if you want to see more about the specifics of cases or deaths or testing. But I do want to show some graphics that got updated. So the first ones are related to this blue dot data that we've been tracking. So if you remember, we'll pull it up in just a second, this is the data where anonymously your cell phone and your other device data gets captured. And so if you've allowed your cell phone to track your location, there's a process by which, again, totally anonymously, we don't know who it is, we don't even have the individual level data, but across the community areas, we're able to see what percentage of the time does that device check in at home? So check in at the home location or within 200 meters of home. And home is defined as wherever that device spends the most time between midnight and 9 a.m. So we recognize people could be on a night shift and could have a different place from home, but nevertheless, it would mean they were traveling. And so let's pull up the graph now. And if we look, you can see that this on the x-axis takes us from mid-February, so before really any orders had come into place, up through early May. And you can see that in early February, our cell phones were checking in about 58, 59, 61% of the time. That includes the time when you're home sleeping. That's the time that you're at home. So throughout the 24 hours, about 60% of the time checking in at home. That's all the time you're sleeping, you're eating, you're at home with your family. 60% of the time we were at home. Again, February, it's cold, etc. And then you can see that as the state of emergency was declared, the shelter in place came in, the stay-at-home order, that really increased to a point, our peak in mid-April there, we were up to 82% of the check-ins across the city being at home. And that was good.
That's great.
It's really great. You'll remember that I really pushed that we wanted that to be at least 75%. We know that not every cell phone can check in at home all the time. Of course, our essential workers are out and about, people need to go to the grocery store, etc. But that was really good when we peaked at 82%. However, starting in late April and then continuing down, we really were falling there, and so you can see that even by the beginning of May, we were down to 74% already and kind of falling. So were we able to get that graphic up? Okay, perfect. All right, so then let's go to the next graphic. This puts some of this, just at a neighborhood level, into some perspective. So on the left, again, takes us back to mid-February. So prior to any of the stay-at-home orders, you can see that across the city, the areas in yellow, the percent of the check-ins at home were between 60 and 70%. And then in orange, they were between 50 and 60%. Okay? So you just get a sense that, in some of these areas of the city, people generally are home a little bit less than in some of the other areas. The red up there, that's O'Hare Airport, so we don't really pay too much attention to that. Yeah. And then on the right, you can see in contrast for this most recent week, our best week, that week where we were at 81%, the whole city was either light green or dark green.
Yes, I remember.
That dark green is 80 to 90% at home, and the light green is 70 to 80% home. And you can see that really as a city, we're going backwards. So we've got some here that are all the way back to the 60 to 70%. We've got a few that are in the 80 to 90%, but we are not staying home as well as we were. And I know the weather is lovely, and I know it's hard because it's been a long time, but some of the, we've seen the curve flatten. We're not coming down the other side of it yet. And if we're out and about and you're interfacing with people outside of your immediate family, at the population level, we see more infections, and every day that we see more infections, it pushes further back our ability to be coming down the curve and to be able to really truly move towards reopening. And then the last map I'll show related to this, I wanted to just kind of put a little bit of a point on this. So, we know that there are different neighborhoods that have different essential workers in particular who need to be out and about. So I don't want people to read this. It's not like which neighborhood is better than another neighborhood. What we're interested in is changes in time over a neighborhood. And so what you see here is this is looking at, we took the mobility data from early April. So the week of April 12 to April 18, when overall we were at 78% home. So pretty good. And then the case data from a couple of weeks later, thinking about incubation periods, how long it can take for cases to present. And the big blue dots show you the areas where we were having more cases that week. And the small dots is there were fewer cases. And so you can see, by and large, that it's not always that the cases go with where people are staying home. So this isn't, it's not like by definition, this necessarily links with each other. But you'll see, we were seeing at that point a lot of cases cases, right, on the northwest, on the southwest, and on the west side, consistent with the data that we've been talking about all along. If you look on the right side here, this pushes us forward another week, where we take the mobility data from April 19 to April 25, where we were starting to fall off a little bit. We then look at the case data just from last week, May 3rd to May 8th. And some of that data will still be coming in, so that's why the dots may not be as big. But again, you can sort of see that, especially like if you look up north here, some of these areas where we do still have a lot of the dark green, seeing fewer cases sort of overall, still seeing more cases, in that southwest and northwest. So anyway, just wanted to share some of that with you because this worries us.
Yes.
It worries us when we are seeing, as a city, we are letting up on the stay at home before we really should. And it is okay for you to be out by yourself when the weather is nice. It is okay for you to be out with people who live in your household, but it is not okay to be getting together with people outside your household just yet. We're all hoping the stay-at-home order will lift at the end of May. It has the best chance of doing that
If we stay home now.
if we stay home now. All right, the last one I wanted to show you, this was a little bit based. We'd gotten a question a couple days ago asking about occupations and essential
Yes.
work and how they can link. And so I wanted to pull this up. This is some census occupation data, and we've looked at this before, but we broke it down a little more. And I think it really helps put a finer point on who has the privilege of being able to stay home and work, and where people by and large in this city have that privilege. And so if you look on the left, this is by census tract, or not by census tract, but by census occupation data. So people reported at a high level the kind of occupation, and you can see that the people who have management, business, science, and arts occupations, the darkest blue is where we have the most of that. So 51 to 70% of people in the darkest blue, you can see especially on the north side, work in management, business, science, or arts. And broadly, especially in the management and business, more opportunity broadly for staying home.
And for teleworking.
Yes, exactly. That's what I mean. Right,
Yes.
precisely. Thank you. Whereas you can see on the southwest side, really, yellow is less than 20% of people sort of have those occupations. In the middle here, this is where people in Chicago live, by and large, who work in production, transportation, and material moving. So we think about essential workers who have needed to be out and continuing transporting things, producing, or in moving. And you see a lot of concentration there. Again, southwest, northwest. And then on the right, people who work in natural resources, construction, and maintenance. Again, in that essential workforce, but in an essential workforce that broadly needs to do work outside of home. Again, a lot of concentration really on the southwest. And so this is what we mean where we talk about where, as a city, we live, we have a lot of the race ethnicity data is very tied to geography here. We are still really quite a segregated city when you
Very
look at how we live. That then you see those same overlap of some of the socioeconomic status or even things like which occupations you live in. Some of this is what then plays into the, the increase that we're seeing in the Latinx community, for example, right now, and some of the increased work that we're doing. So I encourage you to go to the website if you want to explore some more like this, but just wanted to show you some of the underlying data we've been looking at.
Yeah. And it just brings home, we talk a lot about how we need to change the map.
Yes.
And it just brings that home, I think.
Yeah.
Some of the trends that we see across all kinds of information in terms of...
Yeah, and when I think about changing the map, it's not so much about where people live, it's about the way in which the outcomes that can go along with this that put you at risk for bad health outcomes, not just for COVID, but for anything else, how those can track. And we're a little unusual as a city to be able to see that so geographically and solid. Long-term plans.
All right, ready for questions?
Yeah.
Lies Gut from Facebook. How many people have died from the flu in the past in comparison?
Okay.
I don't know if it's in comparison flu to flu or flu to
Probably
COVID.
flu to COVID. So, So what I can tell you is that certainly there are national numbers about this, and I encourage you to go and look at those because flu is a big problem every year. We do track flu here in Chicago just like we track COVID, and so you know how we report out, like you can go on the website and look and see how many people are hospitalized right now with COVID or how many people are in the ICU, and why don't I just do that real quick and pull it up. If I look under latest data and then hospital capacity, I can look and see, for example, that as of right now, there are 494 people who are in ICU beds with COVID-19 or likely COVID-19, what we call a COVID-19 person under investigation with a test result pending. And so that's right now across all Chicago hospitals, about 500 people. I can tell you every week we actually update our flu data. So we do a flu update, kind of in the way that we daily do COVID updates, like weekly during flu season, we do a flu update. And so our latest flu update, it is reportable, meaning you have to tell the Chicago Department of Public Health whenever you have somebody who is in the ICU with influenza. You also have to report deaths, but particularly pediatric deaths we focus on, and then sort of deaths within ICU. So for the whole flu season here in Chicago, we had 479 people be reported into the ICU with flu. So there are certainly many more people who have flu than that, but in terms of people getting sick enough into the ICU, we had about 500 people, 500 Chicago residents over the season get reported in for flu. In contrast, there's about 500 people in Chicago hospitals right now. Those would not all be Chicago residents with COVID. So we are seeing more severe, by far, COVID outcomes than flu here. And that would definitely extend to deaths. Where we look at the deaths, we had 4 pediatric flu deaths this last season. So 4 children under the age of 18 died of influenza. I think in terms of reported flu deaths in ICUs, it was probably 100, something like that. There are more than that, and the medical examiner reports them in. But where we put that in comparison to the 1,356 that we've already had here in Chicago, this dramatically more, unfortunately, than we've seen with flu. And that's what we would expect because the mortality for COVID is quite a bit higher than the mortality for flu. Flu has about a 0.1% mortality broadly. It depends a little bit on the year. But even if COVID has, there's some debate, but 1%, 0.8%, that's still 8 to 10 times probably the mortality of what flu is. So unfortunately, this is killing, including here in Chicago, many more people than flu.
Okay. Richie Vegas from Facebook. For 30 years, no one has been able to come up with a vaccine for coronavirus. So why are we still on hold now?
Okay. So coronavirus, let's just remind everybody, is a family of viruses. So there's 6 coronaviruses that we know of that cause human illness. And 6, I guess, plus COVID-19. Most of them just cause the common cold.
Yes.
So you can get a strain of COVID a strain of coronavirus, not of COVID, that causes the common cold. We don't typically make a vaccine for the common cold. It doesn't kill people. It doesn't cause major problems. So you don't make a vaccine for the common cold. The 2 other strains, the 2 other types of coronavirus that we knew about previously were MERS, Middle East Respiratory Syndrome, and then SARS-1, that's severe acute respiratory syndrome. So SARS, remember, is the one that caused the outbreak back in 2009, where there were a lot of cases in Asia and in Toronto, and that was a big deal at the time. And certainly there started to be work toward a vaccine for that one, but partly because that one did not have this transmissibility that the current one does. It didn't have this problem with asymptomatic spread. It was able to be contained. It was contained. Right? We ended up with like 8,000 cases or something. And so if you contain a new emerging virus, you basically don't need to make a vaccine because we don't see it anymore. And then MERS, Middle East Respiratory Syndrome, that's actually the one. So when I was working for CDC, like I was part of the team that worked on Middle East Respiratory Syndrome. So I went to Saudi Arabia actually, where we were seeing the most of the cases and working with the Saudi Ministry of Health, and really not dissimilar from here, understanding kind of how was that spreading, who was at risk, out doing tests sort of in clinics and actually camels and lots of understanding where that was coming from. But MERS, although there's been some research around it, it also has not shown to be anywhere near as transmissible. And so really for a vaccine to be kind of worth making, we think about first of it typically being deadly or having very severe complications, and it being really pretty easily transmissible. And so, the reason we go to all the trouble to make a flu vaccine every year, and part of the reason why we don't have as many people dying from flu is because we have a vaccine. Because there are, so many people who get it and who die from it. MERS never really took off to the point where a vaccine would be made. SARS got handled and the other one wouldn't. So the fact, though, that we've made as much progress as we have in this amount of time is because some of the scientists could take work that they had already done when SARS emerged or MERS was sort of ongoing, and been able to build onto that some of the work now for the virus itself it's SARS-CoV-2, and then it causes COVID. COVID is coronavirus disease 19 because it emerged in 2019. So working on a vaccine against the COVID, the virus that causes COVID, has been built on the process of making vaccines for these other types of coronaviruses, but we haven't had one before because we just haven't needed one.
Yeah, and the common cold is still out there.
Yes.
SARS and MERS, do people still get those?
Occasionally we'll see MERS, not a lot of it. Where it's seen, it tends to be in the Middle East. Camels actually can be a reservoir. There's a lot that's known about that. So before COVID, MERS is one of the diseases that is reportable. We've had a few cases of MERS here in Chicago and in the area. And I would say prior to COVID, maybe once a month or once every couple months, we'd have a traveler or something coming in who had been in that part of the world, and we'll do a MERS rule out, it's called, where you test and make sure it's not there. So it's in the world, but it's not one that we worry about as much. The mortality from MERS was much higher, but it turned out to not be as transmissible.
Interesting.
Yeah.
Okay. Well, since we were talking about vaccines, I know we had Heather Bench here from Facebook had some questions, I think, related to, I'm not sure. With regards to the test, the virus was never purified, nor was there any gold standard. Oh, this is about the test for the test. The inventor of the test himself said that it was not a diagnostic tool. Furthermore, it isn't binary. Please explain why you're using a flawed diagnostic tool. Why do people only die in hospitals, and where are all the home deaths?
That's a lot of questions. That's a lot of questions. Okay, no worries. So starting from the beginning,
something about
is the virus purified? Was that the question? Yes. So the virus is definitely purified.
And what does that mean?
Yeah. Read me that first part of the question again so we make sure we get it.
With regards to the test, the virus was never purified, nor was there any gold standard for the test.
Okay. So what all purifying the virus means is, when you stick that fancy Q-tip deep in the nose, the nasopharynx it's called, you got to go way back in there. What comes out is a lot of mucus and other materials, and then potentially virus in there. So all purifying means is getting the virus itself, the RNA of the virus, out from all of the other gunk that is around it. Yeah, and so the process that happens in the lab with that, sort of moving from the Q-tip to the point where you can actually get the RNA itself, and then use the primers, use the thing to make sure, yes, this is actually the virus that causes COVID, that is purifying. So definitely that's not a problem. We purify the virus every single time that we run the test.
Okay. The inventor of the test himself said it was not a diagnostic tool.
Okay, so my guess for that is that it's probably related to antibodies. So it is correct that the antibody test is not a diagnostic test, but the PCR test, which is the test that we use with either doing the nasal swabs, or now there are some that you can do mouth swabs or even spitting, those are diagnostic tests. And all that means is that that test diagnoses the presence of virus
Right now.
inside you right now. And so the antibody test is not diagnostic. That's correct, because all it is looking for is the immune reaction that you have had to it. But the PCR, I mean, this is like the most standard diagnostic practice that we use for diagnosing sort of most diseases. So the PCR, so the nasal, the swab, is a very good diagnostic test.
Okay, then finally, deaths in hospitals versus home. Where
Okay.
are all the home deaths?
Okay, so we include deaths here in Chicago regardless of where they happen. We've talked about this a few days, I think, but we keep getting questions about it. So every time somebody dies, there has to be a death certificate, and that death certificate is filled out by a physician. Either that is the physician in the hospital, which is where most people die, or it's filled out by the medical examiner or someone in her office. Technically, if you were in a county that had a coroner that didn't have a physician, it could also be through that. But here in Chicago, we have a medical examiner and her team who are physicians. And so if somebody dies at home, and they go to the medical examiner's office, they can do COVID tests. They do post-mortem COVID tests there and can test and see if that person died from COVID and then record them. So we record both people who die in the hospital or die at home from COVID. And this has been some of the interest where we've talked about looking at the excess deaths that have been seen,
Yes.
right? In that approximately 1 month period, we saw about 1,300 deaths above what we normally see in a given year. So instead, you already take into account all the people who die of car accidents and heart attacks and strokes or flu or whatever it might be. You look at how many you see above that. It gives you kind of an approximation of what's going on. And then over time, you're able to go back and actually look at the death certificates and fill that in a more formal way. So the data that we get sort of right now is around I've been following this person in the ICU and they died, and you count them, but then eventually the death certificate data kind of comes back around, and that's where the final counts come in. So yeah, we get both.
Okay. Brianna Scheimer from Facebook. Is it true that if your child has had RSV last fall or other respiratory illnesses, they are at a higher risk for COVID and complications?
So
And RSV is?
Yeah, respiratory syncytial virus. It's actually the most common virus that puts young, little children, babies, in the hospital. So kind of how we talk about flu season for everybody, we talk about RSV for our infants because it's just a common virus that can cause babies in particular to have trouble breathing and need respiratory support. And so I don't know, to your question, whether your child was born prematurely. Usually, although adults and older kids can get RSV, usually if they're sick enough to be in the hospital, they're usually quite young children. So I don't know whether her child was under one or was kind of, usually it's young children. And most children who have otherwise healthy lungs who get over RSV, I would not consider that to be sort of a risk factor ongoing. However, preemies or other children who have maybe some underlying lung problems are at much higher risk for RSV. So we actually, there is sort of like a vaccine that we give only to premature babies and like the kids who are the most at risk for RSV. So I would say by and large, if your child had RSV last year, does not otherwise have underlying lung problems, I would not be more concerned about COVID in them than anybody else. But if your child had RSV because they had underlying, prematurity or some other lung problem, they would probably be considered to have some underlying problems and probably be at somewhat increased risk from COVID. But RSV itself does not make you at more risk for COVID. It does not say anything about the status of your lungs. And again, by and large, one of the very good pieces of news about COVID is that it has broadly spared children. And so we do occasionally see kids, even here in Chicago, you can look online and see how many kids under 18 have been diagnosed. We haven't actually not had any pediatric deaths associated with COVID at this point. And where we've seen children or even infants and go testing for them, a lot of them do tend to be asymptomatic or very mildly symptomatic. So the concern is as much for them to be carriers as it is for them to be really sick. So I would not be particularly worried about your child, even if they had RSV in the past at all.
Okay. Priya Bandawad Emerson from Facebook. How is 4,500 tests per day 5% of the population? Isn't the number tens of thousands?
Oh, okay, good question. So, so let's break it down. So the population of Chicago, right? The numbers we're talking about for our numbers are Chicago residents, so not the whole state. We've got about 2.7 million people who live in Chicago. So you take 5% of 2.7 million people, and that's 135,000. That's how many people we want to test per month. We don't need to test every person every day. We don't need to test, we're thinking about wanting to test about 5% of people per month. So then you take 135,000 and you divide it by 30 days and you get 4,500 tests per day.
Okay.
So, yeah.
Math. Thank you for the math, doctor. Ayani Good from Facebook. If underlying conditions like hypertension are being medically treated successfully, is the risk factor for COVID-19 reduced, or is it still the same?
Yeah, it's reduced. There's a question of how much it is reduced, and this is one of the things people are most interested in, because for sure, somebody who has hypertension or diabetes or any of these underlying lung diseases, but who is well managed, who is taking, one medicine, two medicines, a couple times a day. If you have diabetes, your A1C, which is your sort of the number that helps you know what your average sugar is, if that's in good control, your risk would be much less than someone who is not in full control. It's probably not all the way back down to if you didn't have it at all. So we know this from thinking about diabetes in other diseases. Like people who have diabetes are at more risk for poor outcomes from a lot of different outcomes. And so you take someone, for example, who has cardiovascular disease, leaving COVID aside, just having diabetes increases your risk factor, but it increases your risk factor like dramatically more for having a bad outcome if you not only have diabetes, but it's in poor control. So for everybody, if you have hypertension, if you have diabetes, take your medicine, do the things you should be doing, have it be in as good control as you can, and you really then do limit your risk quite a bit. You don't eliminate the increased risk, but you really limit it.
All right. This one just came in, I think, because of your answer about the RSV.
Okay.
Blake Nimick, I thought an infant in Chicago had died from COVID-19, but the CDC Chicago statistics show 0% of deaths in ages 0 to 17. Could you clarify?
Yeah, sure.
And it might be someone who didn't hear about
it's
the results
interesting
of that.
how much we've talked about this one case quite a lot. So where we are on that is that there was an infant early on who had died and had been found to have a positive test. But there were a number of, some of the tests were positive and some of them were negative, and it was a very unusual presentation. It was not a child who had been in the hospital for an extended period of time or who had lung problems, et cetera. And so so that's an example, to this point of, does every COVID case count as a death? No, not necessarily. Initially, certainly, the thought was, okay, this is potentially, this baby has had COVID, and but really working with the medical examiner, it's so unusual to have a child die from COVID that you really want to do a full investigation. And so the Chicago Department of Public Health did an investigation, sort of an epidemiological investigation. So we, for example, worked with all of the caregivers for the patient, did not identify anybody with COVID there, did not identify anybody with symptoms, seemed sort of unlikely from an epidemiological perspective. And then some samples were sent to the CDC, actually, and they did some additional microscopic analysis, et cetera. And, long story short, the medical examiner gets to make the final call for this always. But I don't believe she's done that, because there were still some additional samples that they were wanting to look at from inside the respiratory tract down at the CDC. And so that is her call at the end of the day. But really preliminarily in talking to the CDC, there were no signs of the inflammation that you would expect to see sort of in the respiratory tract. There were no signs of the other lung problems that we see related to COVID, and some questions about the testing by and large. And so for the moment, I mean, we'll wait for the medical examiner's final report on that, but we are not counting it as a COVID-related case, and CDC was in agreement with that. In fact, where they've been pulling together at a national level anything we know about COVID in children, have not been counting that case in the national cases, and we're not counting them right now in the local cases either. And then, when the investigation is finished, the medical examiner will release. But it's really, a very, very difficult situation.
Yes.
Really, my team has had a lot of conversation with that family, and so sad. Like whenever an infant dies, and I think when COVID is sort of on top of it, and does it really make sense, and how does this fit in? But this is the kind of investigation that we'll do sometimes, right? To really make sure that if we're saying that a death is from COVID, we really want to be sure that a death is from COVID if there's a question about it.
Yeah.
So more to come, when the medical examiner does a release, but
that explains the data that are being presented now.
That's right.
Okay. It's time for us to wrap up.
Okay.
You've got some good news, some things to do here.
I've got a few things. So first of all, today at 1 o'clock, there is a press conference related to testing. So I know a lot of you always have questions about testing. So
yeah, some today.
Yep. So we'll be the mayor. I'll be there. Some others will be there talking about testing, talking about some new initiatives around testing. So invite you to join in and learn more about that. And then tomorrow we'll probably give some more details on Facebook in the morning. Also tomorrow here at 11 a.m. for our Facebook Live, we have a guest, Faye Tanis, who is a CDPH employee who has been working in our Emergency Operations Center across the city. So she'll be giving some insight into what that work is like, how that fits in. She's a sanitarian, so she's a food inspector usually, and so I think it'll be an interesting conversation, so you'll get a different perspective of some of the response there. Sanitarian, yep. Our number one job at CDPH by the numbers. It's our restaurant inspectors, but she's been doing COVID like many other people have. And then we've got a couple things that folks have sent in. So Big G's Pizza in Wrigleyville is apparently helping feed Chicagoans in need. So you can donate a slice to someone in need. They put it on the pizza Post-it wall, and then anyone can visit and redeem it off the wall, no questions asked.
Love that.
Kind of a nice idea. And then we've got this Young and Restless Facebook Live series. I'm not sure if people have heard about this, but there's Jamal Green has been really one of the folks doing a lot to think about how to get the news out better to younger Chicagoans, to people kind of teenagers and people in their 20s here in Chicago. And so
and the mayor was with him on this past Saturday.
Okay, well there you go. And so there's you can Google it, Young and Restless Facebook, or you can go to on facebook.com/JAYMALGREEN, and there's various things happening. There's like fitness and actresses and open mics, and check it out. Really, doing a better job than we're ever going to do. Probably getting things translated.
Reaching the Young and Restless.
Reaching the Young and Restless, exactly. So thank you very much for that. And we love seeing...
We're restless, but we're not young.
We're restless, but we're not so young. So yeah, if there's other young folks who are really thinking about how to kind of get this news out or doing creative things, we love to hear about them. We'd love to help highlight them. Because when people are younger, it's true that they are less likely to have those really severe outcomes, but they really can spread it, especially to people who are older and have those underlying conditions.
Especially to people that they love.
Exactly. Exactly.
All right. That's wonderful.
News. Yeah.
Please tune in tomorrow at 11 with our special guest.
Yep.
It'll be really good for Chicagoans to get a peek into the Emergency Operations Center and what happens there.
Yep.
Until then, we have to emphasize this for the rest of the month. It's really, really important. We know that people are restless and that they're starting to move around.
We're all restless.
But we're really trying to get to the point where we can come out of shelter in place. And in order to do that, we have to stay strong and stay home.
And save lives. See you tomorrow.